welcome back for part 2, chapter 13. We left off talking about the blood typing system, and so just a little recap is that we use an ABO blood system. You can have antigens for type A, for type B. You could have antigens for type A and B, or you don't have either. If you don't have A or B antigens, then you are called type O. Okay, and then we also looked at the Rh factor, and you may or may not have the Rh antigen. If you do, you're said to be positive. If you do not, you're said to be negative. So you could be type A positive, which would mean you'd have both A antigen and the Rh antigen. We also talked about why Rh factor can be very important for mothers who are Rh negative, right? And that's if she has a baby who's Rh positive, then the next time she has a baby that's Rh positive, she can, her antibodies will attack. So this is why we give the drug Rogam to prevent the antibodies from forming in the first place, so that she doesn't lose any of her future Rh positive babies. Okay, and then this is where we left off. So the U.S. blood type distribution, this does change over time, and this might even be slightly outdated now. But we do see that O positive. So O positive, they only have the Rh antigen, right? They do not have A or B antigen, only Rh. And that's the most, that's the predominant amount of the population is O positive, right? Next, you have A positive, where you have both the A antigen and the Rh antigen. And that's also very plentiful in our population. And then everything else is really small. I actually don't know my blood type. I was going to test it finally this semester, and now we're not meeting. So one day I will actually maybe just do this ahead of time, not wait for the lab. Anyways, they're supposed to tell you when you get blood work done. Your medical record, I'm sure, has your blood type, and you can just ask your physician. So that's another thing I could do. It's just ask my physician. All right, so again, it's super, super important to know your blood type, or to have your medical record have your blood type, so that if you ever have an accident or you ever need surgery, you are ready to receive a blood transfusion with the correct match. On your exam, be able to tell me what about the antigens, about the antibodies, and about transfusions. Okay, we have some sample problems in the lab intro video, and then also I will be doing Zoom office hours every Wednesday during our normally scheduled lecture. Of course, that means just this Wednesday, because then the Wednesday after that is your exam. I'll probably do some extra office hours for that as well, so I'll post that later. But for now, be ready to join Zoom office hours this Wednesday at 12:15, normal lecture hours, and we can do more practice problems. We can review lab and lecture topics that you have any questions about. Just want to make sure you don't feel like you've been left in the dark. Okay, moving on. Blood clotting. So before we can talk about the process of blood clotting, we need to talk about why you don't normally form clots. So when you have the vessel wall intact. We say intact endothelium prevents clotting, and it does this in a few ways. If it's intact, the collagen right below it is not coming in contact with your red blood cells. It's not coming in contact with your platelets. Okay, so when platelets come into contact with collagen, it will start a clotting, the process of clotting. In addition, we have nitric oxide and prostaglandin 12 are being slowly and constantly released by your endothelium cells, and those also inhibit your platelets from activating. Okay, so clotting. You have some of your endothelium has been removed, it's been damaged, and now your platelets are able to come into contact with the collagen. So where there is damage, the collagen is exposed, and now your platelets are going to stick, and that's going to cause them to become activated. So these platelets become activated and secrete ADP and thromboxane. Okay, so thromboxane is going to recruit more platelets, and that's what this TXA2 is right there. Okay, and so that's going to recruit more platelets, and then that's going to lead to this platelet plug. This is not very strong. It's just the beginning. Okay. Then fibrinogen, which is always in your plasma, right, is going to stick to these activated platelets. And so the fibrinogen in the plasma will convert fibrin, it'll convert to fibrin, and that's going to adhere to the clot. So these aqua blue squiggly lines, that's the fibrin, right? So the fibrinogen that's always circulating in your plasma sticks to and converts to, so it sticks to your platelet plug and it converts to fibrin. And this makes the clot, and it's much more stable. Okay, so the 3 steps of hemostasis, not homeostasis. Heme, blood, hemostasis. Okay, vasoconstriction of the vessel, right? You're going to limit the amount of blood flowing through it, right? There's some damage. You need to get under control before you let all the blood flow through it. You also don't completely cut off blood flow, right? Okay, platelet plug, right? Just the platelets sticking to the collagen and becoming activated. So exposed collagen on the vessel, platelets become activated when they come into contact with the exposed collagen. The activated platelets will make ADP. ADP will attract more platelets, and then you will form your platelet plug. We also, like I said, we don't want to completely cut off blood flow. We do limit it, but we don't want to completely shut down the vessel. So we have something called prostacyclin, which will prevent too much sticking so you don't get such a big plug that you actually cut off your circulation. Okay, and then step 3 is the formation of fibrin. So we do have an intrinsic and extrinsic pathway. Not going to worry too much about it, but intrinsic means within, so it's a longer pathway, but it only uses what you have readily available in the blood system, right? Whereas extrinsic means from outside, so this would mean that a chemical that's not a normal component of blood would, like when you get an injury, like a cut. Okay, then you're going to have a stimulus, a chemical that makes you able to take shortcut and get a clot much faster. Okay, but either way, we're going to see that in both of these pathways, prothrombin will be converted to thrombin by factor X. So this is what we call the common pathway, where intrinsic and extrinsic start out differently. There's more steps for intrinsic, but they both end up at this point where that you have prothrombin and it gets converted to thrombin by factor X. Factor X requires vitamin K. If you don't have enough vitamin K, you won't be able to make enough factor X and you will clot more slowly. Thrombin will then convert fibrinogen into fibrin. Fibrin is stabilized with factor 13, and factor 13 happens to be what hemophiliacs are missing. So they have a genetic disorder, they don't have the gene, or they don't have the correct gene to make factor 13, and so it's very dangerous for hemophiliacs to get any type of injury because they can just bleed and bleed and bleed. They don't have the ability to make clots. Okay, now let's say you have your vitamin K and you have your factor 13 and you successfully make your clot. Well, that's great, and that's what we were trying to do. But something to point out is that if it became detached and floating, it's called an embolus, and that's usually almost always lethal because it goes to the heart and stops the heart, or to the brain and cause a problem there. But anyways, it's almost always fatal. Now, if you get a clot in a healthy vessel, we call that a thrombus. This is more common in older patients, and especially the classic example is you have your retired senior citizen who gets on an airplane to take a special vacation that they've saved up for their whole life, and they sit down for 5 hours on the plane and they develop this clot in their leg. Okay, now if they already knew that they have this problem with clotting, more like clotting when they don't need a clot or clotting too much, then you can take a drug called Clotting, which actually lowers your vitamin K so that you can't make your factor X, or you don't make as much, so you won't clot as much. Obviously, you don't want to completely shut that down. Clotting is very important. Okay, so yeah, there you go. So you don't need to memorize each of these pathways. Just want to point out the common pathway, right? Like I mentioned, whether you start with extrinsic or intrinsic, and intrinsic C has a lot more steps, but in the end, they both get to this prothrombin converting to thrombin and then converting fibrinogen to fibrin. Okay, so that's the common pathway where both the extrinsic and intrinsic become the same path steps for the rest of the way. Intrinsic, again, does not require anything extra. It is all already in your blood and vessels. You don't need anything extra. Extrinsic, you would have a tissue factor, and this would be from damaged tissue. Okay. All right, so speaking of vessels, atherosclerosis, I know you all have heard of. We talk about making sure you have a low cholesterol diet and plenty of exercise so that you can lower your chances of cardiovascular disease, which can include stroke, heart attack, right? So what we've been talking about when we talk about all those things is if you get these cholesterol crystals that form and stick to fat within the vessel wall, right? Within the vessel wall, not on the endothelium layer, but within. And if this happens, it, as you can see in this picture, it narrows your vessel. So now you cannot get as much blood flowing, and that puts extra strain on the heart, but also on the vessel itself. And you're more likely to get these abrasions, these ulcerations, and get more damage. And that's going to lead to more and more of this narrowing. And eventually this also hardens. And so now you have not only the narrowing of the blood vessel, but you also have hardening. And hardening makes it even more susceptible to damage. Okay. So atherosclerosis means plaque, and the plaque is referring to this fat and cholesterol crystal deposits within the wall. Okay, so plaque is crystallized cholesterol stuck to fat within the tunica media of the vessel wall. Usually you have some damage to the wall that gets this process started, but not always. If you have high enough LDL, which we call the bad cholesterol, but LDL is a low density carrier of lipids, and it's carrying lipids to the arteries. And what can happen, and what does happen, is that it can actually, as it's moving through the artery, it actually goes into the wall instead, and deposits the cholesterol here. Okay. So cholesterol in and of itself is not problematic. People who don't have any damage to the arteries, people who have really good low blood pressure, like healthy blood pressure, they don't necessarily need to be on a low cholesterol diet, although I always suggest that we be careful with that. But cholesterol is most problematic for people who already have high blood pressure. Now, we talk about diets with low cholesterol, but a lot of people have high cholesterol from their family, right? Genetics. And even with a low cholesterol diet, they still have high cholesterol. So these people usually have to go on medication. And also it's even more important that they exercise regularly. Okay, so what do you do if this happens? If you develop a plaque? Well, you may have heard of angioplasty. This is when they insert a balloon. They insert the balloon right here, and then they pump it up, and they pump it up and pump it up until they flatten out this bulge. And that will typically also allow these fat and cholesterol crystals to be released and disposed of. So that's one thing, treatment that has been really successful in modern medicine. The other common procedure is to insert a stent. And a stent is like, imagine a tiny, tiny chicken wire rolled up and inserted again inside the vessel, and then it opens up and it does the same thing, flattens this out, and it helps to hold open the vessel so that blood can flow through. Okay, so really neat. These are really awesome procedures that save a lot of lives. And so maybe you want to consider a career in cardiology, right? We will be talking a lot more about cardiology in our next lecture as well. So something to consider. So let's see. I mentioned LDL. LDL is the carrier of lipids that when you have a high amount of LDL, you are more at risk to form atherosclerosis. On the other side, if you have a good amount of HDL, then you tend to remove this buildup as it's happening, so before you get a full-blown plaque. And so HDL also can be genetic, so not everyone has sufficient amounts, but we've also seen that good regular exercise promotes more HDL. So guys, if you haven't gotten it by now, exercise so important. It helps promote so many functions in our body and really does help us to stay healthy. Okay, so anatomy, right? You have your arteries, arterioles, capillaries, venules, and veins. Veins are flexible, right? Distensible, and they are at a low pressure. Okay, so they're flexible, they're at a low pressure. We do not have a heart for the veins. We only have a heart for the arteries, right? And about 60% of your blood will be in your veins and only 40% will be in your arteries. So how do we get all of that blood back to the heart so that it can be pumped again into the arteries? Well, we have this return system with these one-way valves, and your skeletal muscles help pump it, and it can only go in one way because of these valves. So another reason why being active is so important. Okay, so and we talked about disease. We talked about atherosclerosis, which is the formation of plaques due to those cholesterol crystals, right? And that is a type of arteriosclerosis, hardening of the arteries. There are other causes like smoking, right? Any hardening of the arteries, whether it's from cholesterol, smoking, etc., always puts you at risk of stroke and other heart disease, other problems. So hardening of the arteries makes you so much more susceptible to breakage and damage of the artery, and that's where your risk of stroke and heart disease come in. Okay, and then this is the one-way valves that I said. So look at this vein. You have this vein here. You have a big one-way valve up at the top of the muscle and another one at the bottom of the muscle. So when the muscle squeezes and it closes off, right, part of this, it pushes on this vein, and blood is going to want to move up and it's going to want to move down. But this valve is closed. It's a one-way valve. It can only let things flow up in one direction. So this is closed and preventing blood from going backwards, and this valve opens and only lets the blood flow up. Okay, so this is how our one-way valves work for our veins. Same exact setup for the lymphatic system, which you'll see when we get to our immunity chapter. And I'm not going to go over all this. You took anatomy already, but take a minute, look at each of the layers, say your names out loud, recall your anatomy. I'm not going to specifically test you on this, but parts of this will come up, especially in our next section. All right, keep up with your studies. Keep up with your labs. Look out for due dates on Canvas. I'm trying to make everything as clear for you as possible. But if anything is confusing, please email me and I'll post an announcement to clarify. Because if you have a question, I'm sure somebody else does too. All right, have a good night.